Hello and good evening. We welcome you all to this webinar today, brought to you by ISAR Haryana. This is a My Sakhi platform of CSR initiative of Jacksonpal Pharma. This is a website which has been recently launched where we are covering the whole life cycle of a woman from adolescence to reproductive age and menopause. Today's episode of Inspire and Ignite is on genetic screening, brought to you by ISAR Haryana. And this is supported by Lycored M tablets of Jacksonpal, Endoreg Dynogest tablets 2 mg, and Cystelia M, the right combination to restore reproductive health. We welcome Dr. Meenu Handa. Ma'am is Clinical Director and Unit Head, Cloud9 Hospital. She will be initiating this webinar today as the Secretary Haryana ISAR. Over to you, Dr. Meenu, ma'am.
Thank you, Dr. Deepika. First of all, a warm welcome to everybody. It's our pleasure to present our Inspire and Ignite Series 6 on genetic screening. These series are presented by the Genetic Committee of ISAR Haryana, and it's a deep pleasure to invite everybody for this. And I now invite our dynamic chairperson, Haryana ISAR, Dr. Jyoti Malik, to please welcome the esteemed gathering.
Yeah, thank you so much. Thank you, Dr. Meenu. And it is actually my pleasure to have a wonderful team, ISAR Haryana, with us. Dr. Meenu as our secretary, Dr. Manju as the clinical secretary, and Dr. Laxmi as the treasurer. And with the blessings of and with the support and constant support actually from our national ISAR president, Dr. Ameet Patki sir, Honorary Secretary General, Dr. Asha Baxi ma'am. We are actually every month we are here presenting on some particular one topic, and this is the 6th series which is now today focusing on the genetic screening. And for this we have our this genetic committee where chairperson is Dr. Moni Bhatia with 2 vice chairpersons, Dr. Shreyasi, Sharma, and Dr. Rachna Gupta. And we are actually blessed to have such bright people in our Haryana who have brought, and in fact, some of us must have read this genetic, this newsletter that was brought, and the articles that they have shared in that makes this complicated topic very, very easy to understand. And actually today I feel my most favorite person. I'm sure she's favorite of so many of us, but specifically to me, she is a great mentor, a great friend, and a guide. And our chief guest today is none other than Dr. Ragini Agrawal ma'am. Dr. Ragini is Director AA Derma Science Complete Clinic for Women Health in Gurugram. And she is founder president of the Indian Society for Aesthetic and Regenerative Gynecology. She is founder president of the Indian Academy of Cosmetic Dermatology and Gynecology. And on 21st, we are going to be witnessing a very beautiful conference which she has designed on this 20th and 21st of July. And I'm sure everybody who's interested in cosmetic gynecology should attend this so as to learn from basic to advanced on this particular incoming new topic and new subject. Then another feather in her cap is the president-elect of the North India Gynae Forum, which she would be taking over next year. So North India Gynae Forum again is going to be another vibrant body with her presidentship. And she has other things we can read on her on this. So yes, that is why I don't want to come between you and Ragini ma'am, because in even small little sentences, she can give us so many insights into many things. So over to Ragini ma'am, and thank you for coming as a chief guest though you are one of us, but still we feel very proud when you come and join us as a chief guest for this platform.
Thank you so much, Jyoti. Thank you. I have no words to say about what you speak. And today's webinar, I think, is wonderful in a two-way, that all my favorite persons are there. You, Manju, Meenu, Shreyasi, and Moni, and others also. But the most important thing, you have taken a subject which is very important to understand the way the genetic factors are coming, and everything is starting from karyotyping is completely gone. Once upon a time, it was the only test to coming to the microarray, complete exome sequencing, and many a time understanding those things is very important. Congratulate you for having such a wonderful topics today, and I know all the delegates who are here, they are really want to listen all the speakers who are, I know, wonderful. I have Meenu, Moni and Shreyasi. Both I have many a time I have listened, and they really a master of the subject. So over to you, continue, and many congratulations, Dr. Manjeet, for your marriage anniversary. Over to you, Jyoti. Thank you again, and best wishes for your tenure.
Thank you, ma'am. Thank you. And Dr. Rachna Gupta is another one person, ma'am, from Sonipat. So Dr.
Okay,
Rachna,
okay.
yeah.
Wonderful.
And
wonderful.
then we have Dr. Vanna Chadda. I mean, we have taken people who are beyond, I mean, I don't think in genetics, if Dr. Vanna Chadda is there, if Dr. Saloni Arora from VLK Max is there, then we have Dr. Seema Thakur is there. So we have selected people from Delhi, from the cream of genetics that we have taken today. So, and Dr. Manjeet Mehta is there, another genetist from Mumbai. So thank you, Ragini ma'am, for your kind words. Over to Dr. Meenu to please now invite our guest of honor.
Thank you so much.
Thank you, Dr. Ragini ma'am, for your kind words. It's always such a pleasure to be always under your guidance and blessings. So please keep doing your support and keep giving us the blessings. Thank you so much, ma'am. We now like to move ahead and welcome our guest of honor for today, Dr. Manjeet Mehta, ma'am. Ma'am is right now, she is the Honorary Secretary General for ISPAT 2023 and 2025. And she has 2 postdoctoral fellowships from Toronto and London. And she's the Director for Clinical Genomics at Life Genomics Lab in Mumbai. And her special interest has been the genetic basis of disease and gene expression. So over to you, Dr. Manjeet Mehta, ma'am, for your kind words of wisdom.
Thank you, Dr. Handa. And congratulations, Dr. Jyoti and the entire team of Haryana, ISAR, Dr. Manju, Dr. Laxmi, for putting together such a relevant program. I mean, genetics is, of great relevance today. It has entered mainstream medicine, and there's been so much of technological advances. The genetic tests are becoming increasingly applicable in our day-to-day practice. Be it infertility testing, carrier screening, prenatal screening, or even a confirmatory prenatal diagnostic testing. Today, there are a battery of genetic tests which are available to help us identify the causes of either male or female infertility, to identify carriers of inherited diseases, to plan antenatal testing, and thereby helping both the doctors and the families to make decisions about the pregnancy. Having so many new advanced technologies, we can now pick the most appropriate techniques for our specific requirements. So once again, congratulations to the entire team for putting together such relevant topics, because an early detection of genetic conditions, it helps us make informed decisions, it helps preparation and planning, it gives a couple peace of mind. I am eagerly looking forward to this event and all the talks and the panel of this session. So all the best to the entire team. Thanks for having me over. Good luck. Best wishes.
Thank you so much. Thank you, Dr. Manjeet. Your presence itself makes the event so grand. Over to Dr. Shreyasi.
It is really heartwarming to see such a great audience and a beautifully curated program. Kudos to the team of ISAR Haryana, especially Dr. Jyoti and Dr. Meenu Handa. Without much ado, I will now kickstart the academic session. We'll start with the first session, which would be the PGT Myths and Realities. We'll first invite the chairpersons for this session. Our first chairperson is Dr. Meenakshi Chauhan. She's a very senior obstetrician at in the Department of Obstetrics and Gynecology at PGI Rohtak. Our second chairperson is none other than Dr. Jyoti Malik. She doesn't need an introduction. She is the chairperson of ISAR Haryana chapter and a very enthusiastic and a vibrant personality. And the third chairperson is Dr. Meenu Handa. She is the secretary of this chapter of ISAR Haryana, and again, a very revered and a senior IVF specialist. Our fourth chairperson is Dr. Anurag Bishnoi. He's a senior embryologist. He practices in Hisar, although everyone knows about her and about her sweet natured and always ready to help kind of an attitude. But it's a pleasure, to talk about her excellence and talk about her achievements that she has. She is right now practicing in Rohtak. She is the ex-consultant Sir Gangaram Hospital, New Delhi. At present, she is the chief clinical geneticist at Noble Heart and Super Speciality Hospital, Rohtak. She has a membership of multiple societies, be it the Haryana Obs and Gynae, ISAR Haryana, NIGF, Stillbirth Society of India, and she has multiple awards and publications to her credit. To name a few are the Dainik Bhaskar Healthcare Awards in 2024, a Powerful Woman Haryana Award 2023, which indeed she is. She has presented multiple papers and published them in journals of national and international repute. She has authored chapters in textbooks of gynecology, genetics, and clinic, and given faculty lectures in societies like AOGD, ISOPUB, ISAR. So it is a pleasure having you as a team member, and it would be a pleasure to listen to you. Over to Dr. Moni.
Yeah, thank you so much, Dr. Shreyasi, for this nice introduction. And it is always a pleasure to meet you all. Wishing you a very happy anniversary, Dr. Manjeet. Without wasting any further time, I'll start with my presentation. So basically, I'll be talking on IVF pre-implantation genetic testing myths and realities. PGT is a pre-implantation genetic testing which has come up in a big way in the last few years, and it is an important test, and many IVF centers are offering it because the main aim is not to achieve pregnancy, but to have a healthy baby and a live born baby. So what exactly is PGT? PGT is the term which is vastly used now. Previously, PGD and PGS were used. That is pre-implantation genetic diagnosis and pre-implantation genetic screening. Screening is for the common chromosomal abnormality, and diagnosis is for the single gene disorder or structural rearrangement, which I'll be discussing in my subsequent slide. So basically, what exactly is done in this? In this, testing is done to analyze DNA from the polar body, blastomere, or the trophoectodermal biopsies. Trophoectodermal biopsy is the best one, which I'll be discussing further, which biopsy is best and why it is best. So types of PGT are the three types of PGT. We all know that there's a cell, in the cell there is a nucleus, and in the nucleus there are chromosomes, and each chromosome contains thousands of genes. So basically, if we are screening for chromosomal abnormality, so we'll be doing it for the aneuploidy, PGT for aneuploidy. And if you're screening for single gene disorder, that is PGT-M, that is for the monogenic disorder. Or if there is a family history of any infertility or recurrent abortion, or if there is any previous child with developmental delay and there is structural abnormality in the previously affected child, or the parent is a carrier of some structural rearrangement, then we'll offer PGT for chromosomal structural rearrangement, that is PGT-SR. So what are the reproductive options available for the couples at the risk of genetic disorder? If the patient plans for the normal conception, then we all know that prenatal diagnosis can be offered by chorionic pillar sampling or by amniocentesis. Or if the patient does not want to undergo termination of pregnancy, if any of the report comes out to be abnormal, then the option of IVF with pre-implantation genetic testing needs to be discussed with the family. Or if the patient is not affording, cannot get PGT done, then the option of IVF with a donor gamete needs to be discussed with the family. So history of PGT is quite vast. It started all in 1937 when Dr. John Rock said that the time would come that the science would progress to such an extent that the parents would be able to have a baby according to the specifications, free from all the genetic disorder. 30 years down the lane, Dr. Robert Edward did sexing for the rabbit blastocyst. Further down the lane in 1987, Dr. Marilyn Monk did PGT for Leishnian syndrome or murine model. The final breakthrough came in 1990 when Dr. Alan Handyside did first successful clinical PGT for X-linked disorder. This paved the way for further testing by next generation sequencing and array CGH, and further offering PGT-M, PGT-A for all the chromosomal abnormalities. So what exactly is done in the PGT procedure? Prior to offering PGT, the patient is usually being seen by in the genetic center by a geneticist, where accurate genetic diagnosis is made, genetic counseling is being offered, and then the patient is referred to an IVF center. In the IVF center, when the IVF is being done, the embryo biopsy is taken and that is sent for the genetic analysis, whatever disorder we are suspecting. According to that, the genetic testing is being offered. And once the genetic testing is done, the normal embryos are transferred. Nowadays, it is said only one embryo needs to be transferred so as to decrease the chance of multiple pregnancy. So there are a number of benefits of PGT. We all know that if we rule out aneuploidy, it increases the implantation rates, lower down the pregnancy loss rate. And for the monogenic disorder, obviously, if monogenic disorder is present, then we'll have to terminate the pregnancy. So it does reduce the possibility to terminate the pregnancy as well. But everything is associated with risk as well. As the benefits are there, there are some risks associated with the PGT. It includes misdiagnosis because we are testing from 5 cells or day 3 or day 5 biopsy is being done. The misdiagnosis is there, though the chance is less, but that chance is there. The chance of embryo damage is also there. There is a remote possibility of mosaicism, and it is very expensive and labor intensive. So now coming on to which biopsy is best. There are 3 biopsies which can be performed: the polar body biopsy, which is done on day 0, blastomere, or the trophoectodermal biopsy. Polar body biopsy does not touch the embryo because embryo damage is not there, but it will test only the maternal mutation. We'll not be able to have any information about the paternal mutation, and we'll have to test a large number of embryos in this case. As far as the blastomere biopsy goes, in this, we'll be able to identify both the paternal and the maternal mutations, but in this also large number of embryos needs to be tested for, and the implantation rate is lower and the chance of mosaicism is higher as compared from the trophoectodermal biopsy. Trophoectodermal biopsy is best because it can be done for all the indications. Rebiopsy can also be done. The chance of mosaicism is very less, but we have lesser number of embryos available which can be tested, and it requires more expertise. So this was a paper published which showed that in ESHRE PGT consortium, it was found that in 2009 and 10, only 0.2% of the trophoectodermal biopsies were being performed. 4 years down the lane, 23% of trophoectodermal biopsies were done. Why? Because it was found that trophoectodermal biopsy has a higher chance of implantation rate, higher chance of pregnancy rate, and lower chance of mosaicism. So now coming on to the indications of PGT. We have already discussed PGT-M, PGT-SR, and PGT-A. The PGT-M is for single gene disorder, sex selection for X-linked disorder, and also for the HLA typing to have a live baby, which is histocompatible with the previously affected child. The other is the PGT-SR, that is for the structural rearrangements. As far as the PGT-A goes, there is always some controversial indications for this. The indication of PGT-A includes advanced maternal age, recurrent implantation failure, recurrent miscarriages, severe male factor infertility, and good prognosis. I put a question mark over repeated IVF failure and recurrent miscarriages because it is very debatable. Some says that it does improve the live birth rate. Some says it does not improve the live birth rate. So I'll be discussing this in detail because these are the important indications. As far as PGT-M and PGT-SR goes, it is very clear to all of us. They hypothesize that PGT-A eliminates the aneuploid embryos, so it does decrease the miscarriage rate, increases implantation rate, and reduces the time to pregnancy. It has been found that if aneuploid embryo is there, there would be early arrest of the embryo. It will lead to lesser implantation rate, more chances of abortion, or if the baby is born, then the baby would have mental retardation. some anatomical abnormality, or the baby may die in utero or after birth. So as far as the advanced maternal age goes, we all know as the maternal age increases, the chance of aneuploidy increases. So the chance of implantation does decrease. So in an article published in Fertility Sterility 2016, it was found that when the pre-implantation genetic screening was performed, with the PGS, the live birth rate was 57% vis-a-vis 18% in which no PGS was done. This was with a single embryo transfer. It was double in case of double embryo transfer. It was 80% with a PGS if performed. So it does improve the chance of having a live born baby in the women more than 37 years of age. As far as the recurrent implantation goes, a study by Greco et al. Found that clinical pregnancy rate was definitely higher in the group in which PGT-A was performed, vis-a-vis in which no PGT-A was performed. But they did not study about the live birth rate. The study by Sato et al. Also had the similar result that in recurrent miscarriages and recurrent implantation failure, the clinical pregnancy rate was higher. But when the live birth rate was studied, it was almost similar in both the groups. So a study was published which suggested that PGT-A does not seem to benefit patients with a recurrent implantation failure to optimize live birth rates. Similarly, coming on to recurrent pregnancy loss, in the recurrent pregnancy loss, in a study published by Dr. Chauhan, they found that the ladies who miscarried was lesser who accepted the PGT without as compared from the ones who did not go ahead with the PGT. But the study published by ASHRAE guideline, they stated that the couples with a history of recurrent miscarriages, they themselves have a high chance of conceiving naturally, and that PGT-A for recurrent miscarriage without genetic cause is not recommended. Similar was the result by the Canadian Fertility Society, in which they found that the women who had expectant management vis-a-vis PGT, the live birth rate, early pregnancy loss rate, and the clinical pregnancy rate were similar. So as far as the recurrent pregnancy loss and recurrent implantation failure goes, going ahead with IVF PGT-A is controversial. As far as the severe male factor infertility goes, in the male factor infertility, what happens? The morphology of the sperms is abnormal. So the chance of these sperms to be aneuploid is increased. So because the sperms are aneuploid, they have a lesser chance of implantation and would lead to infertility in those cases. So in these cases, when the PGT was performed, the ongoing pregnancy rate was 71% vis-a-vis 45% if no PGT was being carried out. There was another study which was published by Dr. Mehmet. In this study, they found that pre-implantation genetic testing for aneuploidy in severe male factor infertility, though the outcomes were improved, but in this case, there was confounding factor of advanced maternal age. So they said that the male factor infertility was not an independent factor which improved the implantation rate in these cases. But the study published by ASRM stated that pre-implantation genetic testing for aneuploidy does improve the live birth rate per transfer. So as far as the PGT-A goes, it has a beneficial role in male factor infertility and advanced maternal age. Recurrent implantation, recurrent spontaneous abortion needs to be discussed with the family. Coming on to low-risk patients, because now what is happening, many times PGT-A is performed so as considering the fact that the patients would have a higher live birth rate. So in the low-risk patients, are we justified if we go ahead with the PGT? I would say no. This was an article published in NEJM journal. They found that cumulative pregnancy rate, the clinical pregnancy, biochemical pregnancy, and the ongoing pregnancy rate was similar in both the groups. In fact, it was comparatively higher in the conventional IVF group as compared from the PGT-A group. So now coming on to PGT-M for HLA typing. If you have a previously affected child, then yes, definitely it can be offered. But any request for HLA typing to create a future donor for the sibling in the absence of specific disease, it is not at all offered. Now, many times, because with the advent of NGS and the other genetic methodologies which are available, many times we get only the mosaic embryos. So what next needs to be done? We all know if there is euploid embryo, then definitely that embryo needs to be transferred in. If there is only aneuploid embryo, then that should not be transferred. But many times, if we do not have any euploid embryo, then what next? If we have only mosaic embryos. So as far as the factors which affect the outcome in mosaic embryos goes, It depends upon the percentage of mosaicism, whether it is a segmental or the whole chromosomal mosaicism, and depending upon the number of chromosomes involved. If the percentage of mosaicism is less, it is only segmental chromosome involved, or the lesser number of chromosomes are involved, then the higher chance of pregnancy is there. So this is the very beautiful article. You can go through the article where they have given the committee opinion what needs to be done if we get the mosaic results. So it has been found that up to 40% of the mosaic embryos have a chance of successful implantation. Why? Because there are chances that they can undergo self-correction. And the miscarriage rate, though, is lower in euploid embryos compared from mosaic embryos, but ongoing pregnancy rate was similar in both the groups. This was the PGT-A report sent to me by my colleague. There were 7 embryos which were formed. 4 were mosaic and 3 were aneuploid. Out of these, in the embryo number 6, the mosaicism was minimal. So this embryo was transferred. Now there is an ongoing pregnancy of 32 weeks. Amniocentesis was also done in this case. The amniocentesis result was normal. So likely the baby would be normal, but the outcome is yet awaited. And this was another report which was sent to me by a senior obstetrician here. The patient stays somewhere abroad. This report showed that only 2 embryos were present. One embryo was aneuploid and another one was aneuploid, and mosaicism was present. So both the embryos were not suitable for transfer. So we advised them that you can plan another IVF cycle and this embryos cannot be transferred. So now everything is not crystal clear. Mistakes do happen. This is an article which tells us about the causes of misdiagnosis and adverse outcomes in PGT. There are a number of causes, human error, technical or intrinsic to the embryo, which can be because of mosaicism, allele dropout or uniparental disomy. So as far as the percentage goes, it is around 0.16% total. Sexing for the X-linked disorder by PCR has a maximum chance of error in these cases. So the ACOG guideline states that prenatal diagnosis after PGT is required in all the cases, irrespective of PGT-A or PGT-M. Any PGT done, it should be confirmed by prenatal diagnosis because of chance of misdiagnosis and error. Now, as we all know about the non-invasive prenatal testing, similarly, it is non-invasive pre-implantation genetic diagnosis, which may be the next revolution in reproductive genetics. This slide I have only put here so as we know that there is something which is non-invasive PGT, which is a matter of research as of now. As we all know, embryo biopsy is invasive, though less chances of embryo destruction are there, but yes, it is invasive. So the novel minimally invasive approaches are: the embryo culture media can be used for further PGT analysis, or the blastocele fluid can be used for the PGT analysis without touching upon the embryo. And it has found that the results are similar to the embryo biopsy. So to summarize, whenever we are going ahead with the PGT, counseling should be offered prior to the procedure. If we are considering mosaic embryo transfer, proper genetic counseling needs to be done. That what is the chance the baby would be abnormal? What is the chance the baby would be normal? Option of amniocentesis needs to be discussed with the family, and chances of mistakes do happen. So after any PGT, prenatal diagnosis is indicated in all the cases. As we know that normal prenatal diagnosis does not guarantee an unaffected baby. Similarly, normal PGD does not guarantee an unaffected baby. Overall, it is a major scientific advancement in producing a healthy baby, but we know we should have defined indications when this testing should be offered. Offering PGT-A in all the cases in low-risk patients is not justified. Thank you so much.
Was very wonderful. I think you've really, in brief, you've covered all 3 PGT, AM, and specifically the other thing that I wanted to impress upon was that even if we have done all these PGT studies, we cannot forego our routine testing.
Yes.
So that is very important. Sometimes we feel that we've done the embryo biopsy, we've done PGT-A, then we can forego. So, but we have to do all our normal screening, has to go in routine as per we do in a normal pregnancy with the double marker, with the NT scan and the other things, or in case needed, maybe further, maybe CVS or amniocentesis if needed. So
Yes,
I think
but
that
PGT, yes, ma'am, but prenatal diagnosis for any PGT we are offering for monogenic disorder or for structural rearrangement, it needs to be confirmed with amniocentesis. But yes, definitely screening as a routine protocol should be offered in all the cases.
Yeah, very nice, Dr. Moni. And you have really given a crystal clear overview of PGT. And I mean, counseling is very important. Huh? Yeah, that is true because many times people, just as you said, so many times people think that it will give us, it is a panacea for all the disorders. But then it is not like that. But then it is important also. And many cases it is really important. And that was nice to know about non-invasive PGT if it really comes then it will be wonderful. So thank you, Dr. Moni. It was very good. Sure.
Thank you so much, ma'am.
Yeah, hi, Dr. Moni. It was really nice. I'm sorry I'm not able to switch on the video. We have started to do the non-invasive PGTA in Cloud9 Gurgaon, but I think we need more cases. We were just discussing last week to really validate our results and but yes, most important is that whenever they give us a euploid, it is very easy for us to transfer, go ahead with FETs or the embryo transfers. But whenever there is a mosaicism, that is something which is very important as a take home, that a proper genetic counseling should be there by a geneticist so that they really understand the pros and cons of the transfer, because they are really keen to go ahead with the transfer, but they need to really understand that as you spoke about the errors of this, I think that was a wonderful slide and very good paper that I think we must go through. And
Just a word,
thank you
Dr.
so much.
Meenu. So with this non-invasive, if you get some, say you get a mosaicism or something, so would you do invasive or then, I mean, the results are comparable to invasive or you would like to
Ma'am, ma'am, actually, there were studies which said, ma'am, we cannot do again, either you do invasive, but the fact is that already the embryo has gone towards blastocyst. That's when the culture is happening from day 3 to expanded blast. And
time
that's
has
the
already
culture,
passed, right?
the culture has been sent. So what is very important by Dr. Moni has said that, ma'am, counseling is very, very important because there is a percentage of embryos which will auto-correct themselves. So, but yes, they need to understand what they are getting into. All the risks should be explained to the patients.
Oh, thank you.
Yeah, we can have expert comments from Dr. Manjeet if Dr. Manjeet is there, since we are another chairperson is not there. Dr. Manjeet, would you like to add anything?
Yeah, I agree with what the previous speaker has said. And this has been, first of all, very insightful talk and very thoroughly covered a topic which is of emerging importance every day. You know, today there are so many technologies available and the knowledge that we are having on those is like increasing by the day. It is really very important for everybody who are practicing obstetricians, you know, to keep themselves updated and abreast of the latest advances. And this is a really good, latest technology which has been around, and more people are getting into this practice.
Yeah,
that's all.
Yeah, thank you so much. Thank you, Dr. Moni. So I think we move on. And now I request Dr. Rachna Gupta to please take over for the second session.
Thank you, Dr. Jyoti. A very good afternoon, everyone. And it's my thank you, Dr. Moni, for such an insightful talk. It's my pleasure to introduce the chairpersons and speaker for the next session. The chairpersons are Dr. Savita Singhal. She is Senior Professor of Gynae at PGIMS, Rohtak. Welcome, ma'am. Dr. Laxmi Goel, Treasurer, ISAR. Dr. Manju Dagar, Secretary, ISAR. Dr. Anupama Sethi Arora, Vice Chairperson, ISAR, also a senior colleague from the same city, Sonipat, where I'm working. So welcome, chairpersons. And can I have Dr. Shreyasi's CV slide, please? Shreyasi is a very dear friend. We have worked together for a long time. And Shreyasi is a senior fetal medicine specialist working in Gurugram. Can I have the CV slide? Although she needs no introduction, she's doing wonderful work in fetal medicine. And she's going to talk about NIPT today. So she's a director of fetal medicine and genetics center in Gurgaon. She's done her NPN fellowship in fetal medicine, diploma in imaging and maternal fetal medicine from Barcelona, and she's certified by Fetal Medicine Foundation. She is also a certified Foxy trainer for ultrasound. He has numerous publications at national, international journals, and she has authored several chapters in various textbooks. And she's one among the 100 inspiring gynecologists of North India, awarded by ET Health World, multiple awards at national and international levels for paper presentation. And I remember very well, she got the best paper presentation at ISRO in Singapore. She was awarded ICMR Research Scholarship and Honor Mentioning Diploma in Imaging from Fetal Medicine, Barcelona. Dr. APJ Abdul Kalam Health Awards 2023 for Cervix Excellence in Fetal Medicine. And her fields of interest are fetal medicine, fetal interventions, ultrasounds, high-risk pregnancy, RHI immunization, and genetics. So over to you, Dr. Shreyasi.
Thank you so much, Dr. Rachna, for such a lovely introduction. And I would always say it was an absolute matter of pleasure to work with you. So I'll be speaking about non-invasive prenatal screening today. Well, NIPS is one test which we all daily talk about. We mention its name at least 10 times a day, be it an obstetrician, be it a fetal medicine. So it is safe to say that this is one test which has, right from the laboratory, navigated its way nicely to our clinical practice. Along with its merits, it has also brought a lot of expectations in the obstetricians and clinicians that, we tend to really expect a lot out of it now. And then that is the context why we are to talk about it in detail and see what are the scopes and limitation, what is the scope of it and what are the limitations, so that we can use it a bit more judiciously. So, talking about the evolution and reflecting at the past, if it's almost 50 years that we've been screening for Down syndrome or trisomy 21. And if we see, we have really evolved in the last 50 years, right from sticking needles to a woman who was more than 35 years of age. We came to the second trimester biochemistry, biochemical screening. Then was the advent of the first trimester combined screening after the landmark paper by Professor Nicolaides in 1992, which really changed the way how we started screening women, and not just for trisomies, but for other conditions as well. It was in 2011 that this new kid on the block came, which was the non invasive prenatal screening. Initially taken with skepticism, it now finds its place very robustly in the American College Guidelines, where it says that it has in a way replaced the traditional screening methods as a primary method. It is preferred as a primary screening method for the common trisomies, which is the trisomy 21, 18, and 13. And the American College says it strongly recommends it being used to be used as the primary screening method. So what we have traversed in the last decade is basically from why to why not. And this is not really surprising because, it does offer a lot. But then this has to be really, it is worrisome because we need to answer certain questions very well. We need to understand the limitations of the test so as to be able to choose the right test at the right time. So, from the initial skepticism, what we have right now is over enthusiasm. We started with whether it can really perform well. Well, of course, it has proven against the test of time that yes, it performs well. But then fetal medicine, for that matter, not just me, more often than not receives phone calls, and when people ask, has it really replaced traditional screening and has it rendered it useless, are the scans still useful, especially the first trimester if there is NIPS available? And once a traditional screening has come positive, is it better to use it as a secondary screening? Does it really replace an entire array of diagnostic testing? And then the questions most asked, two questions which are most asked to me are, if NT is increased, should we do an NIPS? Or if there is an abnormality on ultrasound, should we do an NIPS? Well, I will answer these questions during the course of discussion. We'll first take it one by one, starting from the basics. Why am I saying it as NIPS and not what it is commonly known as, that is the non-invasive prenatal testing? This is something which the laboratories or the commercially, it is the word which is used is NIPT. Well, let us break it down and see one by one. The two words first, non-invasive, is not an ideal description of this test. Why? Because ultrasound is non-invasive, a quadruple marker is non-invasive, and so is a double marker. So what makes it special? What gives it a special status? Then the second part where it says that prenatal testing is also misleading. It's misinformation because it's not testing, it's only screening. So this clearly is not the right nomenclature that should be used. And then American which has actually really come out with a paper which clearly states that this was something which we were not doing right. And even non-invasive prenatal screening is now replaced by the correct term, which is prenatal cell-free DNA screening. So the technology is using cell-free DNA, and we are doing prenatal screening with that. Let's look at the performance metrics. We do know that it performs well. These tables are from the ISPD and the ACMG latest guidelines. We know that the sensitivity for trisomy 21 is quite high. It approaches 99%. But then the question is, are we expecting too much? How do these figures, I mean, they look really nice when we see in these tables. But then there is one very important factor that I have to highlight over here, is that whenever these data was calculated and the sensitivities were calculated, the test failures or the no calls were not included in the analysis. So what will happen is that the sensitivity will automatically increase. What I want to say is that of course the sensitivity good, but then it might not be as good as what is seen in the data today. Then about trisomy 18 and 13, again, the detection rate is good for trisomy 13. It comes down a bit as per ACMG, somewhere around 92%. But that's not all that we have to look at. What we also have to see is the positive predictive values, which would be high for a trisomy 21 because the prevalence is more. However, when we talk of trisomy 18 and 13, if you see the positive predictive value really goes down, especially for trisomy 13 where it is just 37%. That means the true positives out of the tested positives would be very low as compared to trisomy 21. There are reasons for that. The first one is that there is mosaicism in trisomy 13 and 18. And then second is the prevalence is lower. So that is why the positive predictive value over there is lower. So with that background that we know these are the strengths of the test, we also have to know that it's not an answer for everything. There are limitations and challenges that we face daily, and we should be well abreast with those. I mentioned about test failures, and that is one thing which is really not talked much. That is when the fetal fraction is too low, we would not get an answer. There can always be false positives and false negatives. It is not testing, it is only a screening test. Then things like confined placental mosaicism, demised twin, a maternal cancer, a maternal CNV really complicate the situation and where this test does not hold value. Whenever there is an extra source of DNA like a transplant recipient or a recent blood transfusion, again, the test does not hold value. While I enlisted everything on this slide, I know right now they are just words. That is why the idea is to actually take up real clear clinical scenarios and see how they pose challenge in our clinics. So the first case that I'll be discussing is she was a 40-year-old lady, second gravida, previous one absolutely healthy baby which she had. She missed her combined screening because of COVID. She got referred to us as 22 weeks 2 days in view of increased risk of trisomy 18 on NIPS. Now, why I did highlight and showed all those tables of the positive predictive values and the performance metrics is because what it has led to is that people believe once there is a test positive, what they would want to opt for is termination. So It might sound very simple that, okay, if there is a screen positive, the next step is that you have to go ahead and do a diagnostic test. But in reality, I'm sure we all have come across patients who, with a test positive, the first thing that they would want is invasive. And many of us, I'm sure there would be a proportion of us who would believe that, okay, now this pregnancy is doomed and it would be effective. Affected. Well, the answer is no, it might not be. We always have to confirm with an amniocentesis, like in this case where this was an absolutely normal pregnancy. So that's the key message one, that false positives do occur. It's not just a theoretical thing. So there should be no termination without evaluation. Let's come to the next case in which she was a 31-year-old second gravida. She had had an MTP earlier because of caudal regression syndrome. In this pregnancy, because just to provide the better care, she opted NIPS as the primary screening, an absolutely low risk result at a fetal fraction of 5.6. She got referred to us in the second trimester because of the open fourth ventricle. Since she came with that indication, the next thing we have to do is a detailed neurosonography, and we look at the mid-sagittal view. This is the mid-sagittal view of the fetus. It's a 20-weeker. We see a corpus callosum. This plenium we don't expect to be greatly formed at this point of time, but just posterior to it, we see a small avascular lesion, which is supratentorial, a small cystic structure, which is an interhemispheric cyst. So what do we do now? Although this was a very small, less than a centimeter of a cyst, but whenever we see this, we have to offer amniocentesis or invasive testing to the couple. Now, the second challenge that we face in the clinical scenario is once the NIPS has come low risk, no one is ready to believe that there can be a problem. And especially for a finding which is a cyst of less than 1 centimeter, it is a real challenge to counsel the patient. Well, after a 2 day long counseling session, the patient came and went back multiple times. They finally agreed for an amniocentesis only to give us a surprise that it was actually a mosaic monosomy X. Then many of you must be thinking that why did the NIPS miss it? Because it is not the scope of testing. NIPS will not pick up these mosaics. So the key message over here is don't ignore an ultrasound finding even if NIPS is low risk. There can be conditions if NIPS is low risk. Let's look at the next case now. She was a 35-year-old second gravida and a spontaneous conception. She had undergone an NIPS earlier, a low risk pregnancy, got referred to us in the second trimester in view of absent nasal bone. We looked at the ultrasound. There was indeed an absent nasal bone. To add to the marker list, there was an aberrant right subclavian artery also. So what do we do now? Do we just sit there that we have these markers and still, we have NIPS which has come as low risk and we don't do anything further, just reassure or do an invasive testing? Well, when there is an absent nasal wound, there is aberrant right subclavian artery, we do expect that there can be microdeletion duplication syndromes also, so we would not just rely upon an NIPS report. We went ahead, did an amniocentesis, and then this was indeed a trisomy 21 fetus. So, this is to highlight just the way false positives can occur, false negatives also occur. So, despite NIPS being low risk, the baby can still have a trisomy 21, and we will never ignore markers, second trimester, which are absent nasal bone, ventriculomegaly, aberrant right subclavian artery, or increased nuchal fold, because these are the markers which have associations beyond trisomies, so they always would need an invasive testing. So we have covered the common aneuploidies. Let's come to the sex chromosomal aneuploidies. First, we look at the performance metrics. Well, the performance is good. It reaches about 97 to 99%. But then again, I would ask you to focus on the positive predictive value. Especially for monosomy X or Turner syndrome, it is less than 30%. So, this is one scenario where you will see a lot of false positives. Although both ACMG and ISBD say that, okay, this, since the sensitivity is good, it can be offered, but then always remember it needs a detailed pre-test and post-test counseling, and there are ethical considerations. I'm sure each of us would have at least seen one patient where there was a sex chromosomal aneuploidy on the NIPS and the patient did not opt for amniocentesis and went for a termination. This is really a heart-wrenching situation because you know that there could have been just a false positive and the baby could have been just normal. So again, let us just look at the example. So 35-year-old second gravida, she had had a missed miscarriage earlier. This time she conceives spontaneously and gets referred to us because there was an inconclusive report for the sex chromosomal aneuploidies on NIPS and the fetal fraction was quite good. No points for guessing. We have to go ahead and do an amniocentesis. But then before that, what we need to do is always check the parent's karyotype in case it is available. So, it is in our routine practice, we'll always ask that in case parents have undergone any genetic testing earlier, we would want to have that detail. Just by asking that question, the woman said that, yeah, because we had had a miscarriage earlier, we went for a couple karyotype, and only then she produced this report to us where she herself was a 46 triple X syndrome. So, this also gives a message that 46 triple X can be absolutely healthy individuals. And now you know that the mother is 46 triple X syndrome. And what can NIPS give you about a sex chromosomal aneuploidies apart from it being inconclusive report? So anyways, we went ahead, did an amniocentesis. In such scenarios, CVS is not preferred. Amniocentesis is preferred because we do not want any mosaicism. And for sex chromosomal aneuploidies, we would prefer FISH over QFPCR. And the fetus came out to be absolutely normal. So this is the fourth key message, that we know the positive predictive value for sex chromosomal aneuploidies is low, and then always just don't assume a normal parental genotype. It's a very safe assumption to make. There can always be surprises over there. Let's move on to the next case study. This is about a 32-year-old primary gravida. She came at 11 weeks, 5 days. Ultrasound was absolutely fine. At that time, a PAPA and beta HCG was done, which showed a very low MOM. When we calculated the final risk, every risk was fine, but then trisomy 18 was coming in the intermediate range. But then whenever we are talking about very low MOMs of PAPA and beta HCG, we are always skeptical. The patient was anyways aware. She opted for a cell-free DNA testing, and then it came out to be absolutely fine. It came out to be low risk. She comes back for an anomaly scan at 18 weeks, and we find there is early onset FGR. The AC is well below the first centile. The next thing that we want to do over here is amniocentesis, because if there is early onset FGR, there are associations beyond aneuploidies. And once we did that, what we do find is a triploidy. Now, how did that occur? It occurred because methodology matters. The methodology which is used most commonly in our scenario, in Indian scenario, is the random whole genome sequencing, and then it cannot detect triploidies. The only method which is able to detect triploidy is the SNP based method, which we don't use routinely. So that is the fifth key message, that methodology matters, and whenever you're writing a test, it's always best to confirm it from the laboratory that what is the method they are using, because it should be a part of your pre-test counseling. A next very interesting scenario was of a 34-year-old primary gravida who came to us at 12 weeks, 4 days for a routine screening. The ultrasound was absolutely fine, no problems there. But then once the PAPA and beta HCG came, we calculated the final risk, combined risk, and it was coming as 1 in 72. The PAPA was on the lower side, a beta HCG 4.4 mom on the higher side, a pattern which we really don't like. Now, whenever we have a risk of more than 1 in 100, it becomes very difficult to counsel patients. When the ultrasound is absolutely fine, we would prefer an invasive testing. So there was a lot of discussion that went by. She was a teacher herself, And then she said she went ahead with an NIPS, but she came back after like 3 days or so. She said, okay, if you're so insistent that I get convinced, I will opt for an invasing also. So we performed a CVS on her. QFPCR came normal. And again, in the next 14 days, NIPS came normal. And then she said, yeah, see, I told you it was just not relevant for me. And I was like, okay, I don't want to be proven wrong in this scenario. It is fine. I mean, I'm happy if the baby is fine. But then all this happiness went away when we saw the karyotype report. It came back saying that there was a derivative or some extra part that was seen on chromosome 7. So it came on 21st day. And then the next step that we have to take over here is do a microarray, because we want to see the origin of that derivative that we were seeing over there. We see this and we are totally taken by surprise that there was a loss on the chromosome 7 and there was a gain of the 10th chromosome of almost 271 genes. So it was a partial trisomy 10p. And it has pathogenic implications. The baby would be intellectually affected. And in this scenario, they opted for termination. Now, the next thing is that whenever we see balance involving two chromosomes, we really have to know the origin, and we strongly suspect that either of the parents are harboring a translocation which is balanced in nature. So it doesn't stop here. The next step that we did was check the karyotype of both the parents, and the mother indeed had a balanced translocation in the chromosome 7 and 10. So now this entirely closes the loop. Why did NIPS come low risk? Because again, checking for CNVs to this level is not the scope of the testing. It will come low risk in such scenarios. So this is not what we should expect out of it. And then now, once this entire thing is solved, she has reproductive options for the next pregnancy. Dr. Moni just mentioned about PGT, while she can also opt for a prenatal testing. So the key message over here is the use of NIPS should be judicious when we are talking of using it as a secondary screening tool. Once a primary screening comes positive, the first thing I have seen is, most of the clinicians would want to just write an NIPS and get a report. And if it is low risk, we don't really want to bother further. But then one should always think that why, if everything was fine, the biochemistry came, and then the combined risk was more than 1 in 100. So if the risk is more than 1 in 100, we actually have to prefer an invasive testing. Let's now talk about the rare autosomal trisomies. We've spoken about the common trisomies, the sex chromosomal aneuploidies, the surprises that we come across in our clinics. Now moving to the rare autosomal trisomies. What are these? Anything apart from what we have spoken already? You must have seen the NIPS reports, and you would be very happy when you look at these and they are all marked as low risk. Well, the answer is, what is the relevance of all this information that is provided? Well, you will be disheartened to know that the positive predictive value is just 11%. So none of the important bodies really recommend it for the routine care of unselected populations. Then why is it being done left and right? It's because nowadays some labs are not even giving an option of running only the trisomies which we would want. They would just come and the form will only have either all trisomies or microdeletion and duplication. If we do tend to run it and we have a report in which a positive result comes, we need a specialist management. In such scenarios, there's a high likelihood of CPM and high chances of uniparental disomy. So we don't prefer to do a CVS, we would prefer an amniocentesis. But then to start with, it's best if it is not routinely offered. And once if there is a report that is saying that it's a high risk for any rare autosomal trisomies, then there has to be a detailed counseling session for the prospective parents, and they have to opt for a further invasive testing. So that's the key message 7, that routine screening for RATS is not really beneficial. coming to the microdeletion and duplication syndromes. So, because we have enough and more genetic laboratories, and then there is enough and more data that is available, we come across, fancier tests that this is advanced NIPT, and then this is more advanced NIPT. So the terms becoming more superlative exciting, while you really don't know what content it is bringing us to. So with that, let us discuss about what is really the advanced NIPT, what the labs offer to us, which they say they can check microdeletion and duplication syndromes. So, talking of MMS, 22q11.2 deletion syndrome, or the discharge, is the most common. There's a slight disagreement between ISPD and ACMG with this regard. ACMG says, like a conditional recommendation, that for 22q11 deletion, it can be offered to all patients. However, ISPD says that we would not recommend it routinely. But apart from this, leaving aside 22q11, both the societies agree that they should not be routinely offered to an unselected low risk population. Why? Because the data is not validated. We really don't know what we're checking, and then once the result comes positive, we will be doing unnecessary amniocentesis, and mostly it would be a false positive. So, that is the next key message, that routine screening of MMS merits further validation till we have better data. This advanced and or more the fancy NIPS should be just kept aside and not to be used for an unselected population. I know by now most of us are thinking that why these labs keep giving us such information, and we are really attracted to that once they say, okay, this can detect this as well, and we think, okay, the scope might have extended. So it's a very beautiful study which systematic meta-analysis was published in the prenatal diagnosis, which actually went and saw that there was a review of internet advertising to potential users by the commercial companies. And the conclusion was very interesting, that the information provided on many websites or by these companies do not comply with professional recommendations. So you should always remember that, that information that is provided to you may not be what the professional recommendation is. So it's always best to go back to them. Having dealt with that, now let's come to the part of what happens when there is increased NT. Is there a role of NIPS over there? So there is no doubt in that NT is still relevant. We have to do the first trimester screening. And when we talk of an increased NT, let's just try and understand this with an example. She was a 24-year-old second gravida. Previous one MTP was done because of a lethal skeletal dysplasia. She came to us at 12 weeks, 5 days. We saw that the NT was above the 95th centile for this baby. The next step, should we opt for an NIPS or an invasive testing? We will get this answer if we understand the associations. The associations are not just limited to aneuploidies. We can have microdeletions and duplications, which I just mentioned are not a scope of NIPS. And then we can have single gene disorders like Noonan's, which again are not a scope of NIPS. And we can have other chromosomal abnormalities like triploidy, which I just showed is not a scope of NIPS that we are routinely doing. So, even if everything is fine and NT is borderline increased, the next thing that you have to do is do an invasive testing. I would really want to mention this paper over here where this is an Australian paper, and they were facing challenges because people would come with a low risk NIPS result, and after that would go for the first NT scan. And once the NT comes positive, they are really stressed out and they think that, is invasive really relevant? Well, the answer is yes. The moment NT is more than 95th centile, we have to opt for the CVS. Like in sex chromosomes, amniocentesis was preferred in increased NT. In contrast to that, this is a situation where CVS is preferable because the DNA is more and we can check for a single gene disorder also on a later date. After we have done the invasive testing, next follow-up would require checking for the anomalies at the early anomaly scan. anomaly scan at 20 weeks and a fetal echo subsequently. Once everything is fine, only then can we say that, okay, the baby might remain fine based upon the percentages which are designated for the different values of NT. So for this patient, now it goes without saying, we went ahead and did invasive testing. The QFPCR came normal, the microarray came normal. Routinely, we would call the patient again at 16 weeks and then do an early anomaly scan and then decide for a whole exome sequencing. Since she had earlier had a second trimester MTP for a lethal skeletal dysplasia, they had opted for an whole exome sequencing upfront, and then we had a diagnosis over there. It was an obsesmodysplasia, a lethal skeletal dysplasia with an autosomal recessive inheritance. We checked the same variant in both the parents, and both the parents turned out to be the carriers. By that time, the pregnancy was 16 to 17 weeks. These are the postnatal images, and with that, I would close the section on increased NT just by giving that one key message, that whenever you're seeing an increased NT, please don't debate it. Don't say it is just marginal, it is just a little more, everything is fine, it might resolve. Well, whenever there is an increased NT in the first trimester, it needs, and it really needs, a diagnostic testing. Then, what about a structural abnormality on ultrasound? You can imagine, if I'm so much vehemently defending the role of invasive testing in increased increased NT, what would I say for any structural abnormality? A structural abnormality can have any gene. So, when the testing is done, it has to be with regard to the phenotype we are seeing. And then that answer can only be, we can get that answer only by an invasive testing and not by a screening test. So if we are seeing a structural abnormality on ultrasound, be it a megacystis, a cleft, a cardiac condition, any effusion, a diverticulum, the next step we have to do is check the fetus and do the invasive with regard to the phenotype. Let's just see one quick example. Now, this baby had a binder phenotype or a mid-facial hypoplasia. Apart from that, there was a premature ossification of coccyx and there was epiphyseal stippling. And in this scenario, we do know, when we see such features, we do know that the association is with chondrodysplasia punctata. So I know anything less than whole exome sequencing will not give us a complete answer. So we did do an invasive, checked to the level of whole exome sequencing, which came out to be normal, and the baby is absolutely fine. So this is my key message 10, that whenever you see a structural abnormality, the phenotype genotype correlation has to be made, and NIPS is just not the right choice. I mentioned it earlier in my talk that when NIPS comes low risk earlier, it becomes very difficult to counsel the couple when there is an ultrasound finding. But we must always remember that despite it being low risk, if there is a structural abnormality, then for a complete answer, we might have to resort to an invasive testing. Very quickly about multiple pregnancy. Well, the performances of NIPS is good for twins, and then we can perform it for the routine aneuploidies. But the scenarios that we see are very interesting. This was a 32-year-old primary gravida. In this pregnancy, it was an IVF conception, and there was an early demise of one twin. She went ahead, did an NIPS, came as a high-risk report, and then got referred to us at 16 weeks. I think we all know it's beyond debate. We have to do an amniocentesis, which we did, and it came out to be absolutely normal. And this brings to my next key message, that whenever there is a vanishing twin, there are higher chances of false positives. So it's always best to wait. You can wait for 8 weeks, is as per what guidelines mention. And if you're really keen on doing an NIPS, you can do it after 8 weeks, and especially when no fetal node or no other part is visible. Then we just had a beautiful session on PGT, so I think the session cannot close without having a mention of the PGT, especially when the forum is of the fertility specialists. So this was a 40-year-old primary gravida Now, this was a scenario where she was having very less number of embryos which were formed. Every time there was the embryo was coming coming with an aneuploidy, and the only one embryo which she got, which could be transferred, was having a low-level mosaicism of trisomy. It was a mosaic trisomy 3. So this was a transfer which was done. And whenever such an embryo is transferred, Dr. Moni rightly highlighted, it has to be confirmed by an invasive testing. And when we do an invasive testing in these scenarios, since it's a mosaic, it's the amniocentesis which is preferred over CVS to avoid confined placental mosaicism. So we went ahead, did an amniocentesis. We have a fission microarray which were absolutely normal, and then she has a healthy outcome now. So this is the key message 12, which would be more of a reaffirmation what Dr. Moni has already mentioned earlier, that we need a reaffirmation of PGT with an invasive testing. So after this entire lengthy discussion, I know we are back to the skeptical mode. Yes, that is it even a good test? Well, there are benefits. It has better accuracy than any other screening for the common aneuploidies. But then, we should not forget the concerns. The problem now is it is too widely available and the information is so simplified that it has, rarely been interpreted in its own way. And that 99% detection rate, people have translated it to every other thing possible. And, there is a lot of misinformation about it. So the thing is that what should we do? If we have a good test and we really want to use it right, we have to set the expectations right. And there is the role of pre-test counseling. It's best to hand over a patient information sheet to patient, which we do it daily in our routine practice. The 4 important things that you should always tell your patient when you're offering this test to them is what they should expect out of this test, what they should not expect out of this test. There would be a possibility of a no call or the failure of this test. And then, in case the result is positive, further testing would be needed. It would not just mean that they have to terminate the pregnancy. Once you have made this amply clear, I think there would be lesser challenges once you do a postnatal counseling. And with that, I will give the concluding message that, it's a beautiful test. It has one such test that has been practice changing in a span of 10 to 12 years. It has really changed the way we are doing screening now. But then, we really don't have to be over enthusiastic about it. We can use it in the best way only when the application is with diligence and attentiveness and the use is judicious for better outcomes. Thank you.
It was indeed a wonderful talk, Dr. Shreyasi. So I think the message was very clear that, we should be using this test judiciously. Judicious use of NIPS is very, very important. And all the 12 key messages and all the cases were excellent, were brilliant, because every key message was an important message and that was a take-home message.
It was an enlightening talk by you, and we all understand now that NIPS is not an answer for everything, and it is always a pleasure to listen from you. So now coming on to the last part of this webinar, we'll be having panel discussion. The topic of the panel is optimizing the application of genetic investigations in prenatal care. So we have with us Dr. Rachna Gupta. She'll be moderating the panel. So she is well known to all. Can we have the Dr. Rachna CV slide? She's a director and senior consultant, Sonipat Fetal Medicine and Genetics Center, Sunehri Devi Hospital. She's a visiting consultant, Apollo Center for Fetal Medicine, and she has done her fellowship in neurology from Israel, and her main interest is fetal neurosonography. She's an executive member and general secretary, FMF India, and she has numerous publications to her credit. So we have eminent panelists with us. We have Dr. Vandana Chadha. She's a renowned figure in the field of fetal medicine. She's the director of Sattva Fetal Care, and she has numerous publications to her credit. She's a member of Fetal and Genetic Medicine Committee, FOXY. Then we have with us Dr. Neeru Thakral. She's a senior gynecologist and IVF specialist from Gurugram. Then Dr. Divya Agarwal, she's a dear friend of mine and she's a consultant in medical genetics in the Trust Apollo Hospitals. Then we have Dr. Kirti Kishore Sharma and Dr. Saloni Arora. They are fetal medicine specialists. Dr. Kirti is from Rewari and Dr. Saloni Arora is practicing in BLK Max Hospital, Delhi. So to add to this panel, we have an expert in the field of genetics, Dr. Seema Thakur. She's a senior consultant practicing in Fortis Hospital, Shalimar Bagh, Delhi, and she's running her own genetic clinic in Dwarka. And she's a senior executive member in prenatal genetics and an executive member of Society of IEMG. So on behalf of ISAR, I welcome you all. Looking forward to listen to you and learn from you all. Over to you, Dr. Rachna.
Thank you, Dr. Moni. A very good evening, everyone. And I'm very happy to be. Can I request everyone to mute the mic?
Continue. Yeah.
Okay. Thank you. So this is like going to be a very good discussion amongst all the fetal medicine and genetic specialists and IVF specialists. Dr. Neeru Thakral is an IVF specialist, Dr. Divya and Dr. Seema Thakur, they are geneticists. Dr. Vanna is both fetal medicine and geneticist. Dr. Kirti and Saloni, they are both fetal medicine specialists. And they're all my very good friends. So it's going to be like a discussion amongst friends. Okay, coming to the first case. So a very common scenario that a woman presents to you at 22 weeks. She's second gravida, first child is alive and healthy. She has missed all previous screening. And on the anomaly scan, we are seeing an isolated finding of absent nasal bone. Rest, everything looks okay. So can I ask Dr. Kirti, how are you going to counsel this patient and investigate?
Hello, hi. So first of all, thank you for including me, Dr. Jyoti, Dr. Moni, and Team ISAR in this panel.
Kirti?
And
Yeah.
can you hear me?
Yeah.
Okay. Okay. So first of all, thank you for including me, Dr. Jyoti ma'am, Team ISAR, and and I think this is a good way to continue with the previous talk. So in this case, the first step would be a detailed scan to see if any markers or anomalies. And I'm assuming that this is an case with isolated absent nasal bone. So in that case, I would tell the patient that this condition is going to be, this is a marker which can be associated with chromosomal abnormality, particularly trisomy 21. But also we now know that it can be associated with pathological CNVs, especially microduplications, which are pathological. So now she's 22 weeks, so that also needs to be kept in mind. I would like to offer her a diagnostic test with and a chromosomal microarray. And that is how I would like to proceed. And I would also like to reassure that an absent nasal bone does not mean that the nose is absent or the child is not going to look normal. That is also a case. Now, having said that, one of the common scenarios in context of the previous talk is a lot of patients come directly and ask for a cell-free DNA testing or NIPT testing in these cases. But as has already been highlighted very thoroughly in the previous one, given that she's 22 weeks and we already have a marker positive, I would discourage from a cell-free DNA testing in this case.
Thank you, Dr. Kirti. So here we did perform an amnio. We counseled the patient. Patient also asked for the option of NIPT, as you rightly said. But we convinced her that amnio would give us a quicker answer and a more comprehensive information. So the first result, the QA-PCR came normal. But on microarray, we have this, just a second. So it fits into chromosome 1q21.1 microduplication syndrome. So views about this particular syndrome. She's already now 23 plus weeks and 23 plus 6 where we got the results of CMA. And it was a difficult counseling. I would like to ask Dr. Divya how she will handle this.
Thank you very much, Team ISAR, and I'm very to be a part of this esteemed panel. Thank you, Dr. Rachna, for the cases. So for this particular case, now we have a duplication, which means there is a copy number variation, which is present at the long arm, which is the Q arm of the chromosome 1. And it's called copy number variations, as we all know, you know.
Hello, hi, ma'am.
I think there is a lot of disturbance. I'm not too sure from where is it coming, but I'm hoping that it's gotten better now. Yes. So as we can see that, you know, the copy number variations are actually some deletions or duplications that could be present in our genome. And then there are some specific regions on the chromosomes which are particularly prone to these deletions and duplications. And there is a reason why these areas are very prone to getting deleted or duplicated, because these areas on our chromosomes are sort of flanked by some specific regions and some specific sequences of the DNA, which are called the repetitive sequences. And that's why they become, you know, very prone to error, like deletions and duplications. So these are known as recurrent copy number variations, and they could be present in normal individuals as well as in the patients where we could see effects of these deletions and duplications in the form of, postnatally growth restriction or prenatally growth restriction, postnatally in the form of developmental delay, or prenatally in the form of structural malformations. So, these recurrent copy number variations, they have a reduced penetrance, which means that they may express in some individuals and they may not be expressing in certain individuals. So this particular duplication that has been detected for this patient, a 1q21 duplication, is a recurrent copy number variation, which has a reduced penetrance, which means that it may not express in everyone. So how do we give a clarity on this particular chromosomal change that has been detected in a fetus in whom there has been an absent nasal bone? So there are a lot of recommendations that have been given on the basis of various studies that have been done. And these are huge studies that have been done in the normal individuals as well as in the diseased individuals as well as in the diseased fetuses, which have detected these recurrent copy number variations. And according to these, when we go back and look at the literature and the databases with these chromosomal copy number variations, these very special copy number variations, we will get an idea about the penetrance. So as you can see here in this paper, we've just highlighted some recurrent deletions and duplications, and 1q21 duplication is highlighted in yellow, which means that it has a moderate penetrance, which means that that the penetrance of this particular genetic change is somewhere around 20 to 30%. So about in 20%, it will express itself. It might lead to a phenotype. In others, in 70 to 80% of the cases, it may not lead to a phenotype. So now when we have this information, how do we give further clarity to the family that, in this particular fetus, whether it will express or not? So, there is no one correct 100% answer to this question. However, the things that help us in aiding for the counseling are that there is always an ascertainment bias of the CNVs in a prenatal setting. Prenatal setting, if there is a structurally normal fetus or there is a fetus with only minor markers in the ultrasound, there is, the presence of these copy number variations might be just incidental findings, and the presence in the detection of these copy number variations in a prenatal setting are associated with a much better outcome as compared to the detection of these copy number variations in a child, say, with a developmental delay. So based on that, we counsel based on the fact that, the family history, we take an elaborate family history and we look for any other members in the family with neurodevelopmental problems or malformations. We try and, test for the similar copy number variation in that affected family member, and then try and give, clarity whether it could express in that particular family or not. And most importantly, we do the parental testing. A lot of these recurrent copy number variations would be present in the normal looking parents, in the apparently normal parents, and the presence of these copy number variation in the parent, in one of the parent, further is reassuring for us that it is probably not going to express in the fetus in in a way, in a severe form, and it is probably just an incidental finding that has come into the fetus because of, the partner. A very, very important point here is the analysis of the region that is deleted or duplicated. So we look at the critical genes and we review that, what is the area that is exactly duplicated? What are the critical genes that are involved in this particular region? Are those critical genes also described in previously reported recurrent duplications or not? So, based on on definite analysis as well as some correlation, for example, correlation with the phenotype with which, for the reason for which the test was done. For example, in this case, it was just the absent nasal bone. So we go back and we look up that, that with these particular duplication, is there a facial phenotype? Are there any previous cases where, absent nasal bone has been described? So a genotype phenotype correlation. So on the basis of all of this, then we have to, sort of counsel the family whether it would express and how far it would express. But nevertheless, it is sort of a difficult counseling whenever we get these kind of copy number variations which are recurrent and which have a decreased penetrance. So,
thank you, Dr. for such an elaborate counseling for these cases.
Is Dr. Seema there?
Sorry? Yeah, sure, ma'am, please.
Is Dr. Seema there? Otherwise,
yes. Ma'am, Dr. Vanna, please go ahead.
No, I'm just saying.
But Dr. Vanna, ma'am, please go ahead.
Leaves the field really open for the debate whether isolated hypoplastic nasal bone at least should undergo. Because I was looking at this paper by Z et al., which is the bigger number, where they found the 7 CNVs. Of them, 4 were found also in the parents. And all of these babies delivered and had normal sort of neonatal outcome. The ones where it was de novo, they terminated. The other way to look at it is we've probably done more than 300, 350 absent nasal bones or hypoplastic nasal bones where we've only done karyotype in the first 15 years of my career. So I don't offhand remember getting because mostly you would get a feedback. Sometimes you want of a baby which was neurodevelopmentally normal. So I think Dr. Seema, you can comment on that. So of the, I don't offhand remember even the ones where we only did karyotype, we have ever got a feedback of a problem which happened. So I think that data also can be looked at.
Yes. Yeah, so actually, in this particular case, because now we have totally moved to the like microarray. So the report says likely pathogeny. So first, let's understand how we should interpret the report in the context of this case. So since this is likely pathogenic, so first thing is that no direct termination, because the word is likely pathogenic. So we must assess the parents. The parental segregation is a must to check whether it is de novo or inherited. And the third thing is that the clinical features. So of course, in this particular case, there is absent nasal bone, which has been reported in 1Q duplication. So clinical feature is definitely there. We need to test the parents by microarray and also tell them that this condition is a very, too much of counseling dilemma. In case, suppose this is inherited, as Dr. Divya has nicely highlighted, that there is a variable expressivity and incomplete penetrance. So these are the counseling challenges in this case, and the decision to continue or terminate cannot be given, in a definite manner in this case. So this much the couple should know, that even if this is inherited, the problems may differ he may be entirely normal, or some child may be having some developmental delay or some other issues. So all these challenges need to be discussed with the family so as to completely guide them. Then the other part which Dr. Vandana has highlighted, I agree with her. There has been, we have been doing absent nasal bone since ages. And our initial workup was only limited to the fish also, many a times only fish, what to talk of karyotype. And very, none of them came back and said, okay, I had absent nasal bone and then I still have developmental delay and you did all the tests. So this again explains that even if there was some micro deletion or duplication, so it may be that, there is a variable expressivity or incomplete penetrance. So probably these are the reasons. So we need to, counsel the family in this way, that even if this is inherited, there may be chances. So this much limitation must be highlighted.
So thank you very much. I actually kept this case because we are always in a dilemma when you get a copy number variant in benign, so seemingly benign phenotype, and you don't even have time, like you are at the edge of 24 weeks. Then if you are doing parental CMA, suppose it is de novo, and then you're almost like 27, 28 weeks, then they have to apply for medical board for if they still want a termination of pregnancy. So I think this scenario, the best would have been like if they had, and we could see whether this was an inherited or de novo variant. Wouldn't that have been a good situation?
So if it is, inherited, that gives you the assurance, a big amount of assurance. But yes, a small amount of limitation must be highlighted to them, because this particular duplication is reported to be, incomplete penetrance and also the variable expressions. So because this is, that's what is highlighted. So at least we cannot say that nothing will happen.
What is the incidence of CNV in the general population? That also the parents need to be.
Yeah.
Like if you do for anyone, you will find something.
Yeah, we keep seeing, sometimes I've seen 10 MB duplication in the mother. And then generally we say the size matters. So you see, 10 MB is a huge size. And she was absolutely fine. And the fetus also had the same. So all these, why this all is happening? Because, when the microarray came into the practice, we didn't have the control and the case per se. So immediately it went into the services, and that's why you don't have enough control so as to guide us who is normal with this micro duplication or who is abnormal with this. So there is lack of scientific knowledge also. So all these, as a clinician, we must know before we offer any termination based on such kind of reports. And they need genetic counseling not from the genetic counselors. They need genetic counseling from the clinical geneticists who have the knowledge of both the clinical scenario as well as the practical scenario of the neurocognitive outcomes and all. And so this is what
another good idea would be to have some sort of a national board or a national body, where if you have a termination of a 24-weeker based on a hypoplastic nasal bone and a genetic finding, which it should be interpreted by a team of experts rather than an individual person. I mean that was another sort of thought.
Most of the time, they are not reaching the medical boards.
Dr. Divya and people like Seema could be part of that kind of expert committee.
Yes, Dr. Vandana, interesting that you brought it out, because just about a few weeks back, a couple of weeks back, we have the MTP board at Apollo, and there was sort of a similar scenario, and the pregnancy was, and we had a recurrent copy number variation, and it was a de novo change while the fetus was structurally normal. But the difference here was that the nephew of the mother was also affected. And then we went back and checked for we repeated the microarray in the mother, and then the mother was a carrier. of this copy number variation, which got missed the first time. So, there was an inherited copy number variation, but with an affected child in the family with that particular copy number variation. So although the penetrance is less for that copy number variation, but, so we, in the MTP board, of course, as highlighted by you, that, they had a genetic expert, they had a fetal medicine expert, they had an obstetrician, because there were some obstetric issues also in that family. So, I think when the pregnancy, legally, when it is happening, and when it's happening in a proper way, then the discussion does include the experts, the relevant experts. Of course, when it is not happening legally, then obviously, then no expert opinion is taken.
Only the reports are, taken into the consideration, and there is so much beyond these reports to understand. Even we understand every time we read the report, and we try to understand to a significant extent. So just on the basis of one likely pathogenic, the message from my side is that only there is no urgency to terminate. Better to refer them to the experts like Divya, Dr. Moni, which are around you. So so that they can guide you in a correct manner. The availability of all these techniques should be, we should try to do not to do harm, based on that principle. Yeah, so Rachna, I think
Right. Yeah, moving on to the next case.
Yes.
I mean, this is this absent nasal bone is always a matter of discussion and a never ending one. So coming to the next one, second gravida, 35-year-old, previous child is alive, and his time history screening was low risk. She was referred in view of anomaly scan done outside, suggestive of mild bilateral ventriculomegaly measuring 10 to 11 millimeters and poor visualization of cavum septum pellucidum. So we repeated the scan, and at 19 plus 1 weeks, her growth of the fetus was on 23rd centile. Head circumference was on 49th centile. We are very particular about the head biometry in cases of any CNS findings. And there was a bilateral mild ventriculomegaly, and we also saw that sulcation were a bit delayed. At 19 plus 1 week, we should have seen a parieto-occipital fissure, which was not seen here. It looks quite flat. And we saw the cavum septum pellucidum was very well visualized. And on the sylvian fissure, we saw that it lagged again a little bit behind. As compared to 19 weeks, it appeared a bit shallow. So, and this is a clip of the same patient. You can see the ventricles look a bit ballooned, but rest of the parenchyma is kept. The lamination is well seen. There are no irregular ventricles. Posterior fossa appears normal. The corpus callosum, CSP, everything appears normal here. So rest of, apart from the mild ventriculomegaly and mild lag in the sulcation, rest of the structural anatomy was kept, and we did a detailed anatomy survey, which was fine. Apart from these CNS findings, there was nothing else. So, Dr. Neeru, how will you counsel this patient who has presented with a bilateral mild ventriculomegaly?
Thank you, Dr. Rachna. First of all, I must congratulate Dr. Jyoti and Dr. Moni for the excellent kick start of this genetic committee of the ISAR. So regarding the counseling, because this is a case of ventriculomegaly, mild ventriculomegaly more than 10 mm. So ventriculomegaly is an important soft marker. I should say is a major soft marker. So I will advise this patient for the invasive only, and I will definitely defer NIPS in this case. And I'll counsel that there are a lot of high chances to be association with the genetic with these patients. There can be any chromosomal anomaly. There is a great association with the chromosomal trisomy 21 also. And there can be part of the infections also. So I will rule out torch infection, send the amniotic fluid for the karyotyping microarray and also for the DNA PCR to rule out the infection. It could be associated with the toxoplasma. There could be association with the cytomegalovirus. And there can be some isolated brain structural anomaly also, like agenesis of corpus callosum, Arnold-Chiari, Dandy-Walker. So I will definitely counsel the patient for the invasive test. And most important is here, I will let them go to some fetal medicine specialist or geneticist, clinical geneticist to have a proper review before deciding anything.
Thank you so much, Dr. Neeru. So, yes, importantly, whenever we have any patient referred with any finding from the outside, we do repeat the scan to make sure that this finding, whether it is isolated or associated with any other abnormalities. And in CNS findings, we have to explain even the seemingly borderline findings, they may evolve later on as the CNS, the brain is a developing structure. So even if your genetic tests are normal, important thing is that you still need to follow up every 4 weeks because we can have evolving abnormalities later on. And here also we saw that sulcation were a big delay. They could catch up or may not catch up. So all this needs to be explained to the couple. So Dr. Saloni, how are you going to investigate this case?
Hello, everyone. Thank you, Rachna ma'am. Thank you, Dr. Jyoti. So Dr. Neeru has already made my work a bit easier by saying that there is no role of NIPT in the cases where we have a brain conditions, which is a major soft marker for chromosomal problems and the underlying genetic syndrome. So here I would, so ventriculomegaly, whenever we have, as Rachna ma'am said, we need to investigate, we need to scan the baby to see rest of the structural anatomy and rest of the markers. And ventriculomegaly is like a fever. We have to look for the causes. So going by one, that we have to rule out first the genetic causes. So we will offer patient or rather advise amniocentesis, and amniotic fluid here need to be tested for basic common 5 common aneuploidies, that is QF, PCR or either by fish. Then we send same amniotic fluid for a microarray to look for microdeletion and duplication, and that too with a 750K resolution. And some DNA has to be stored because another common reason of ventriculomegaly, particularly in this case where we have a slight doubt about the sulcation, which could be underlying cortical malformation. So once microarray is normal, then we might need to do a whole exome sequencing on the stored DNA. Dr. Neeru mentioned that she would like to offer a torch PCR. So in clinical practice or as such, if the maternal torch serology is not indicative of recent infections or there are no other signs of fetal infection, it is a good practice that we can do a CMA PCR or torch PCR. But usually if rest of the thing is fine, then we can defer it also. Then the third thing is, it is not end of the story, as Rachna ma'am said, that once the genetic tests are normal, we still need to follow up this baby, and that too 4 weekly follow up by ultrasound. And also many a time the MRI is offered at the same setting where the ventriculomegaly is diagnosed at 20 weeks, 22 weeks. And I would like to highlight here, if us as a fetal medicine specialist, and especially the Rachna ma'am who has done a fetal neurology fellowship also, and we are confident that the brain is looking okay, we would like to defer MRI at this stage, and we would like to do it in the 3rd trimester. So I would like your opinion on this, ma'am, because many a time at the same setting at 20 weeks only, the patients are referring with the MRI being done, and then it becomes a challenge that we tell them that once the genetic tests are fine and you have to repeat at 32, 33 weeks, and they are saying कि पहले हो तो गया madam, दोबारा क्यों करना है? So what is your take on this, ma'am?
For me, this is like, I have had couple of cases who come with an MRI and it is reported as normal, and then we repeat the neurosonogram, we see Joubert's anomaly, when it is being reported as a Blake spout cyst in the previous scan or something, and or we are seeing corpus callosum dysgenesis when MRI says normally seeing corpus callosum. So MRI before 24 weeks are completely useless. And after 24 weeks also, it should be suggested by the person who is doing the ultrasound whether he or she thinks the MRI is going to add upon it or not. If not, then please it out until 32 is really who understands the brain anatomy and can first screen on the ultrasound and then advise MRI if it was going to help out in any way at that point of time or not. And this is what ISO guidelines also say about fetal MRI, that it has to be advised by the fetal medicine person, not directly as a routine investigation or even if the brain abnormality is suspected, unless until the person has already undergone a detailed fetal neurosonography. So as a protocol, we waited for the CMV, PCR, CMA, which came back normal at 20. At that time, we did not go for West directly. We called her for a follow-up to see whether the ventricles were increasing in size, were stable, or they reduced in size, and how were the sulcations evolving. So at 22 weeks, we saw the fetal growth had come down from 23rd to 12th centile, the head circumference from 49 to 31st centile, but the ventricles looked absolutely normal. They were measuring 5 to 6 millimeter on both the sides. And also we could see here the parieto-occipital fissure has now appeared. So there was some hope. We see nice parieto-occipital fissures, the ventricles looking normal, the cavum septum pellucidum looks normal. And here also the sylvian fissures, now the sulcation, the depth of the sulcus has improved. So it gave us some hope. Okay, that looks like probably a delayed development, but nevertheless it is happening. And a reduction in the size of ventricles gave us some positive hope. And we continued her for a follow-up, actually without doing this at this point of time. But at 26 weeks, what we noted, the findings, they were a little bit concerning in the sense that the biometry of the head, the head circumference, it was continuously showing a downward trend. Now it was on the 11th centile. Growth was maintained on the 11th centile. The ventricles were asymmetric, but both in the normal range. And let's look at the cavum septum pellucidum. Okay, so the cavum septum pellucidum looked a bit broader than usual. Can you see this? This looks very broad. So I was a bit suspicious here, but now the sulcation were very normal. The sylvian, parieto-occipital, and the calcarine, all the sulcation looked normal. The concerning features were downward trend in the head circumference and a funny looking CSP asymmetry of the ventricles. And at this point, we initiated whole exome sequencing after discussion with the couple. And Dr. Vandana, ma'am.
Yeah,
Vandana, ma'am.
So I think till 22 weeks, it looked like it seems okay. And that's the tricky part here, Rachna, that a lot of times when we see these babies, there's such a lot of overlap with normal phenotype in the prenatal setting that's very hard to take a call on whether you're anticipating a bigger problem or not. And I think with the at the 26-week scan, when I see the asymmetry, the fall, etc., and that leaflet looking little abnormal there, it's a good idea to start the WES, because with the new law, with the PNDT law changed, and with the courts being much more liberal with the committees letting us do feticide for babies where we anticipate severe mental delay, etc., neurodevelopmental delay, it makes sense to do the WES for this particular presentation at the moment.
Yeah, thank you. And so we did, and this was the report. It showed a compound heterozygous likely pathogenic variant in the PCNT gene, and this is supposed to cause a disease called as MOPD type 2, microcephalic osteodysplastic primordial dwarfism type 2. So because the report came likely pathogenic, the baby is now already 29 weeks, 3 days. Before informing the report, I again scanned the patient. There was a further decline in the head circumference. HC was now on the 5th centile. Fetal growth also on the 5th centile, and humerus measured less than 1st centile. And on the neurosonogram, this CSP, one of the leaflet completely disappeared. Ventriculomegaly reappeared, and the shape of the ventricle looked very funny. And this is a cine of the patient. So we see the ventricles are again ballooned up, and there is disappearing one leaflet here on this side. So there are 2 leaflets, and then you see this is not there. So This were the findings at 29 weeks, 3 days. So can I ask Dr. Divya, do you agree here with the reports, the genotype, and does the phenotype match here? What do we tell the patient about MOPD type 2?
So yes, so there is, to an extent, I would say that, there is a correlation, because this particular condition is a condition of primordial dwarfism, primordial short stature, which means that there is intrauterine growth restriction, which is noticed primarily in this particular condition. So there is growth restriction, which has an onset in the prenatal period, and along with that, there is a symmetric growth restriction. So this particular gene is involving the pericentrin. The gene involves the cells, actually the cell turnover. So it basically causes a cell proliferation defect, leading to the shortness as well as the microcephaly. So this is it. The microcephaly is because of a neuronal proliferation defect. And it's not, a neuronal migration defect that it causes usually. And hence the microcephaly, and the earlier suspicion of a migration defect, like, the sulcation problem, was not sort of confirmed later on in the ultrasound. So I would say that there is a reasonable genotype-phenotype correlation in this particular case. And these children do have, some of them will have a mild intellectual problem, or commonly they will have a normal neurological outcome, but the main problem remains in growth. And then there are some associated systemic problems also. So it is not a predominantly neurological condition, as was we were sort of getting the suspicion that there is by the ultrasound that there is a particular neurological condition which is probably affecting only the brain. But this particular genetic condition is a systemic condition with involvement of the neuronal cells as well, leading to microcephaly. And in fact, the neurological manifestations are not as severe, but it is sort of a condition which needs medical attention sort of throughout life, but for other reasons. And again, there is a variability of the complications that might occur. But the important thing is that should be communicated to the parents, is that the neurological outcome may not be like, moderate to severe neurologically. The child may not be impaired. It might be mostly a normal outcome.
So what I was worried also about here,
I'm sorry,
that disruption of the leaflet, could it have been some vascular release? MOPD is known to have.
Yes.
Just a second.
It's better now. I of the question. Thank you. So yes, MOPD does lead to some complications, some vascular complications. So MOPD can lead to some vascular complications later on in life. It has been seen, but these vascular complications in the fetal life are less prevalent. They are less often seen, and they leading to neurological malformations, disruptive malformations is not a common presentation for MOPD. So rarely, malformations because of the vascular disruption might occur, because it is this particular condition is known for a vasculopathy also, rarely. But we'll have to look up if rarely does cause the vascular lesions prenatally, leading to disruptions.
So that is one of the mechanisms they say for the disruption of the CSP leaflets, a vascular insult, because the small vessels supplying that leaflet might be affected. So anyways, and as you said, the neurological outcomes are excellent, but they may have strokes due to vascular reasons. And so we counseled the parents, and they had the option of applying for the late termination to the medical board, which they did. And we advise the parents for the variant segregation for the, again, to finalize the recurrence risk that it is indeed it is a autosomal recessive inheritance or not. So, Dr. Seema, ma'am, will you like to add?
Yeah, not add, just it's definitely a very interesting case. And my primordial dwarfs, they are actually very small type of dwarfs, which is where they have the failure to thrive. So it's one of the rarest abnormality. Even in, I have seen only 2-3 cases, and most of them, they will have just a very subtle feature and to pick up, like the FGR will be not very gross type of FGR. So because this is a prenatal onset fetal growth restriction, so my message is that in any case of ventriculomegaly, in any case of ventriculomegaly, one should order the neurosonogram, because that was the only clue for this fetus to undergo further testing and to diagnose such a rare condition. Right.
Also, another thing is that if I had ordered VESIC 19 weeks and suppose I had a report by 23 weeks, I wouldn't have had a phenotype-genotype correlation by that time, isn't it?
Yes. So, of course, both the variants were easier for you. They were likely pathogenic and you would have done segregation in time so as to give them in a more definite way. Right here, because of the paucity of the time, you couldn't do the parental, because sometimes, very occasionally, this may not be biallelic. You may. So the parental, in all such cases, given the enough time, the first important thing is to confirm that whether this is biallelic, that coming from the both parents, right? So although this is clinically matching, so we didn't discuss much, but for the common, understanding, whenever these type of results come, the parental segregation analysis is a must for that only, so that we are doing right things, even if
I would still, ma'am, still one more question. If I didn't give microcephaly as a clinical feature, will they still come up with this variant?
But actually speaking, this was not a microcephaly. I would not say this is a microcephaly.
I mean, because in my clinical findings, I wrote HC on 5th centile, a downward trend. So that was one of the main reasons why I asked for whole exome sequencing. Suppose I do it as in a baby where the head circumference is on 50th centile. Will the team look for this variant in that case?
This is all HQ. No, ideally they should all, they are supposed to report all the pathogenic findings. So of course, this is a pathogenic and likely pathogenic only. So probably they would have reported. But in the absence of microcephaly, I'm not sure whether they. So did you put the word microcephaly? So probably,
but I did
speaking,
this was not on 5th centile.
Yeah, so that,
not microcephaly, but head circumference on 5th centile was one of my main clinical features highlighted on the requisition form.
Yeah, so they would have used ventriculomegaly, and probably this is pathogenic and partially matching, so they could have done. So probably they could have done in this case, but many a times they fail to do so because of the woos and all, not in the pathogenic cases.
Okay, great. So let's move on to the next one. Okay, this patient, primary gravida, do we have time or do we call it a day? How are the rest of the people?
We can take it quickly.
We can discuss this one. This is very interesting. We can discuss.
Yeah.
Okay. So, primary gravida, non-consanguineous, 20-week scan, she has come for a routine anomaly scan. We have noted polydactyly in this fetus on the first trimester, and also I called her back at 16 weeks because of this finding. There was polydactyly post-axial, both hands, both feet had pre as well as post. So you can see in the foot there are 7 toes. And interestingly, the father also has the same phenotype. So in the feet, he still had 7 toes, but in the hands, the post-axial polydactyly had been removed. And there was some history of cystic mass excision near the umbilicus, which was removed at the birth. And so far, so good. At 20 weeks, when I'm doing the abdominal scan, I see this cavum septum pellucidum doesn't look as nice as it should. On the right side, you have a normal looking CSB. you can see a bit of hypoechoic corpus callosal fibers, but here you don't see that corpus callosum in the anterior part of the CSP. And the frontal horns, they are not as well defined. And this one looks a bit broad, the one dependent one. The one towards the probe is hidden in the shadow. And the one which is dependent, it looks a bit ballooned. So we resort next to the TVS neurosonography. And what we see here, the corpus callosum is thick, the anterior part is missing. So we call it as a dysgenetic corpus callosum. And what about the rest of the brain anatomy? The vermis looks normal, rest of the parenchyma looks normal. There is a bit of increased extra-axial fluid, and the head circumference was also on the 95th centile. Father also had a large head, so that was conforming to the paternal phenotype. So these are some other images, again showing the dysgenetic corpus callosum and the frontal horns, giving a picture like, where the corpus callosum is missing in the anterior part, it looks like a picture of the agenesis of corpus callosum. But we know here in the sagittal view, posteriorly, there is a CC, which is very thick and abnormal looking. So again, we took a history for the father, if there was any history of intellectual developmental delay. And what we got to know, there was a motor delay till 3 years of age. There was a lag of 3 months in achieving the motor milestones, but there was never an intellectual history of epilepsy. So, Dr. Divya, again, coming back to you, how will you counsel this patient point of time?
So first of all, I would like to, say that it was so good that, you, apart from doing the ultrasound, the fetal ultrasound, you had a look at the feet of the husband, and you could pick up that, sometimes patients, couples may not come up with that information on their own for a variety of reasons. One, they may not feel that it is relevant, and some may not come up with various other reasons. So it was good that this was noticed, and this definitely is, some autosomal dominant genetic phenotype. As soon as, we see a crossed polydactyly, which means preaxial in the feet and postaxial in the hands, we have very few conditions genetically that present with a crossed, what is known as a crossed polydactyly. And once you tell me that, you're having a dysgenetic corpus callosum also, and you have the head size on the larger side, then we can narrow it down further to this particular condition, Greek cephalopolysyndactyly. GLI3 related gene disorders are autosomally dominantly inherited, and they do not lead to, most commonly, they do not lead to any sort of intellectual problems, and they do give rise to this crossed polydactyly. And this would be our first clinical suspicion and clinical differentials. Of course, the crossed polydactyly is also seen in certain other skeletal problems, like Ellis von Crevald, but they would be easier to identify also because they will have a severe phenotype, as well as the inheritance pattern will be recessive. So it's for us to counsel the family. Ideally, yes, we would want to do a genetic test and document that this is GLI3, and definitively counsel them that this condition is benign. But even if we don't do the genetic test, then clinically, if I'm seeing the father intellectually absolutely normal, and I know that, that this condition is fitting in absolutely, I can counsel even without with a reasonable degree of confidence that this fetus, has the same condition as the father, and neurologically, these children will do very well. And unlike a lot of other genetic conditions that we have been talking about, this particular condition has absolutely, has very, very less variability in the phenotype within the same family. So it has not been seen, if the father is intellectually fine, then the child will be most likely intellectually fine. So of course, for a definite, there are some rare genetic phenomena by which, this thing can differ. And, there could be some rare cases where there can be a difference in the presentation. But overall, I think I would like to reassure this family, and of course, giving them the risk of recurrence as well, that this is most likely a gene which is getting transmitted again, and it will have a risk of recurrence for 50%, and they need to be aware about it.
Okay, thank you. Dr. Kirti, will you like to offer here a fetal MRI or parental MRI? We discussed about the fetal MRI in the last this thing, but here the situation is a bit different.
So definitely, so fetal MRI, as we've already discussed, it will be at the discretion of the fetal medicine specialist, both the decision whether to do or not, and second also when to do or not, which is also key, because we can't have, there might not be any use for repeated MRIs at the same time. So in this case, if we have a satisfactory transvaginal fetal neurosonogram at 20 weeks, then we can defer the fetal MRI, or if the fetal medicine specialist think something might be added to that information, go for it for sure. Parental, we definitely need a paternal MRI in this case, and also a serial review of if the parent has had a fetal MRI, their own MRI done at an earlier age. And I would also like to review those previous as well as the present status.
So here my challenge was, the parents thought baby is exactly like father. If father is normal, how can baby have any neurological abnormality? So I had to see whether the father had a normal corpus callosum or not. And also I had to have another modality to prove, yes, the corpus callosum of the fetus was dysgenetic. Sometimes parents need more convincing. So we did take it, we have liaising with the good fetal radiologists who can tell us they will be able to comment on the corpus callosum in a decent way. Though we waited until 21, 22 weeks. We didn't do an MRI at 19 weeks. We waited until 21, 22 to make sure we have some concrete information. And we did the father's MRI. The corpus callosum was reported to be absolutely normal. No partial agenesis, no dysgenesis. Absolutely all the segments were present in the father's MRI. There was mild diffuse prominence of sulcation, which was given as a normal variation. So this did have a different phenotype. So Dr. Saloni, how will you investigate in this patient? What will you like to do as the next investigation given this picture?
So, ma'am, definitely Dr. Divya highlighted that she is thinking in the terms of having the same gene the fetus has inherited, and the intellectual ability is going to be the similar. But now, once we have done father MRI and the phenotype is different, so we would like to see what's happening with the fetus genotype. So I would like to offer amniocentesis, where the amniotic fluid need to be tested for microarray as well as for a whole exome sequencing, to confirm that whether there is the similar gene is there or there is a difference in the genotype of the fetus as compared to the father.
Right, so we did want both the tests, but somehow this family now, after going through so many investigations and everything, they decided for a termination of pregnancy. They did go for amniocentesis and a microarray, and DNA was stored, but an exome was never performed even after repeated requests. I mean, even after termination and the CMA was normal, we did have a discussion. We had a consult that we need to do an exome sequencing, but there was so much distress that they deferred it, did not go for the exome sequencing. Dr. Neeru, may I ask you, if this patient now wants to get pregnant again, what are you going to tell her for the future pregnancy?
Since it's a good thing that we have stored DNA for the patient. So this patient, she was a patient of infertility and undergone IVF. So now this time, if we want to do the IVF, I will definitely go for IVF with PGT-M. So as we have definitely good that storage of the DNA, with the DNA storage, we can do the exome testing and can know which type of gene defect is there, which single gene defect is there. So in the, I can go for blastocyst, and then from blastocyst, I will test which genetic PGT-M will get the probe made. Probe can be of the informative type, or probe can be of the new protocol type. And they will, geneticists, they will make the probe and they will check the genes of the parents. They will check the genes of the DNA, same probe they will make. And we will now rule out with the biopsy, PGT laser biopsy will check if there is the same, and whichever is the healthy embryo, that only I'm definitely going to be transferred.
So here, I wanted to highlight the role of the obstetrician to ensure that the exam had been performed before the subsequent pregnancy. This patient did have a secondary infertility, and what they did was they did an IVF with the self-gametes with no exam being done. And this is what she presented to me with at around 8 to 9 weeks in her subsequent pregnancy. She has conceived TCTA triplets. And I performed the NT scan where fetus 1 looked apparently normal, fetus 2 had multiple abnormalities, and fetus 3 had a similar phenotype in the first trimester as the previous fetus that we terminated, or like father, that there was polydactyly, post-axial in both the hands and pre as well as post in both the feet. Rest apparently normal, but of course I cannot tell about the corpus callosum at this point of time. So, Dr. Vanna, ma'am, how will you counsel now this patient? Vandana, ma'am.
Sorry.
You're on mute.
Yeah, okay. So your task is made easier, Rachna, over here because you already have a baby presenting with the abnormalities. So I think we would go in and reduce the one with the suspected brain and heart abnormality at the moment. Now, it's again a lot of counseling if they wish to continue the one with the polydactyly on the assumption that it might have a normal presentation as the father, or they would later on look at the brain and then decide on a late feticide after the phenotype evolves. That could be discussed further with them. But I think at the moment, let's do the fetus 2 and then kind of wait and watch a bit and decide, or however the couple wants. At least they have one healthy baby there. So that's key.
Do we do any genetic testing now?
The whole exome, previous baby's DNA is still there?
No, it was 3-4 years back. So I inquired from the lab, it has been discarded.
Okay. I think because you have one healthy child there, and I would probably, as a practical point, I would probably keep the normal looking fetus and not really do a lot of testing. But I would give both options to the parents. So if they want, we can extract the DNA of the one with the polydactyly, do the testing, do the but does it really help us in decision making?
That is the point. Like if I find the genetic mutation,
if you think it through, I think just follow the phenotype and decide. Just
Can
follow the ultrasound. Yeah, please, Doctor.
I think also I just wanted to just bring in that the corpus callosum dysgenesis is seen in 20% of GLE3 patients, and that in spite of that, we say that intellectually these children will do fine. I do understand that, you know, the parents will be anxious, and we will also be anxious if we are seeing a normal corpus callosum in the parent, and we are saying that, you know, don't worry, the child also has a similar phenotype, but then we are saying that, but then there is an additional finding here neurologically. I can understand the anxiety, but medically and scientifically and evidence wise, the presence of corpus callosum dysgenesis also does not predict a bad neurological outcome.
Yes, I think
so I think at the moment our best bet is to follow the are they keen to carry on twins, or
they are happy to carry on twins. I'm worried.
I think you can leave the ball in their court and tell them that if the phenotype is exactly like the previous one, you would still offer them a late feticide. If after a lot of counseling and meeting with Dr. Divya, they decide that this is going to be intellectually normal and the CC is not bothering them, then let's. But you know, all of this is assuming that
everyone wants a guarantee that the baby has to be neurologically normal, and who
then
will give the guarantee?
And then the rare events where you're thinking it's what the father has and you end up with some third thing. So all of that discussion has to be done with them.
And also the question of reduction at a later date, in case it ends up with an abnormality.
Yeah, so the late feticide is going to have higher risk of pregnancy loss overall also. So all of those percentages need to be discussed with them.
Yeah, so here again, I would like to emphasize the importance of pre-pregnancy counseling, and PGTM would have been quite helpful here. And if we didn't have the recurrence, PGTM would have been so useful in this patient.
I think also meeting the expert who would probably define the phenotype for them well and kind of give them the assurance that this seemingly is a normal. So that could also make things easier.
Mm-hmm. Okay, so she's still ongoing at 16 weeks. I have already seen her. The twins look fine. One is absolutely looking fine. The other one with polydactyly, waiting for the 19-week scan. Haven't offered genetic testing so far, but I will speak to them. Like Dr. Divya said, if it is BLE3, we are more hopeful of a good neurological outcome. At least we should have that information in hand, even if there is a corpus callosal abnormality on the DIC scan. So very, very insightful thoughts from everyone.
Thank you, Dr. Rachna, for the excellent and interactive panel with
Thank you so much
many geneticists and so many fetal medicine. We all learned a lot, actually.
So I think that was, Neeru, I would say it was amazing. It was awesome. It was brilliant. It was mind-blowing. It was impressive. And it was majestic. So you all guys have done a wonderful, wonderful job. Right from our expert, Dr. Seema, right from our panelists, Dr. Kirti, Dr. Neeru, Dr. Divya, Dr. Saloni, and Dr. Vanna, and our moderator, Dr. Rachna. You
And
guys
our
have
expert,
been
Dr.
awesome.
Seema.
It was like, we were all so, it was new to us actually. So many things and so many syndromes, the names that we've learned today, the GCPS and so many other things. It was very, very informative. And the talks were amazing. Dr. Moni was superb. Dr. Shreyasi was another, I think her lecture and her case presentations were another thing. So many points that we could learn from today's webinar. And I would like to thank you.
Hope we have recording.
Yeah, we'll get the recording. दोबारा 2-3 बार सुनेंगे तभी जाके हमारे we'll get to understand what all you guys have said. So we'll get the recording, I think, in another 3-4 days, and we'll put it in the group. And thank you so much, Dr. Moni and Dr. Shreyasi and Dr. Rachna, for organizing the whole show and for giving us so many nice inputs. And I'm sure we all must have benefited a lot out of it. So thank you so much. And anything else you would like to add, any of you, Dr. Moni or Dr. Rachna, Dr. Shreyasi?
Yeah. No, thank you so much. And in fact, the panel, you said so many words. I'm speechless. The panelists, the moderator, everything was wonderful. Thoroughly covered cases. Thank you so much, Dr. Rachna and all the panelists.
Thank you, everyone.
Thank you, Dr.
Thank you very much for having us.
And thank you, Jackson Paul, for giving us this opportunity and for giving us the platform. And we have another now on 23rd, we would be again discussing 2 important new articles from Fertility Sterility on in our up to date with updates series. So if we would like to see you all again on 28th webinar,